welcome on behalf of entire Lupin team in this unique Foxy initiative, which is called E-Sampark. And today we are going to learn the 14th module of E-Sampark, and for which we have none other than Dr. Kundan V. Ingale among us, who is renowned gynecologist and obstetrician and IVF specialist. He is the chairperson of Foxy Infertility Committee for year 2020 to 22, General Secretary of POGS, Pune Obs and Gynae Society 2019 to 20, and also has got various awards. Award for Best Research Paper in ESA 2018, ESA 2019, and third Best Research Paper for Foxy 2019. He is a fellow of Indian College of Obs and Gynae. Has served as treasurer for Maharashtra chapter of ESA between 2011 to 14. Has been a founder member of Pune Association of Gynae and Endoscopic Surgeons, director of Nirmiti Clinic Center for Assisted Reproduction and Endoscopy in Pune, and also has served as treasurer of POGS in year 2016 and 17. He published the first research paper and presented it during the 6th COGI World Congress at Vietnam on use of GCSF subcutaneously for thin endometrium, and also presented RCT on fresh ET versus FET at IFFS World Congress at New Delhi in 2016. He has many research papers on his name and is a prolific teacher as well as researcher. And today he is going to speak on Anti-Mullerian hormone, when to measure and what is its significance. So with this, would not take much time and would hand over the session to Kundan sir. Over to you, sir.
Thank you, Dr. Vinay, for that such a pleasant words of introduction. Thank you very much. Friends, I am extremely sorry for joining 15 minutes late because of medical emergency, but I'll start my task, which has been allotted to me to speak on AMH, when should we do and what is its significance into our practice. So friends, I think whenever we want to understand about any particular topic, we need to always better to understand the the physiology first regarding that. And I think the folliculogenesis is something which is very, very important, which I feel that to understand. So we have, it starts from a germ cells, which gets converted into primordial cells. Then postnatally, these primordial cells, they will convert into primary follicle. Then primary follicle will get converted into pre-enteral follicle. From pre-enteral, then the enteral cavity opens, and that is called as a enteral follicles. Now the result of enteral follicle can be either it goes into a pre-ovulatory stage or it can go into the atretic follicle. So this is a kind of a life of follicle from right from the beginning till the complete ovulation. Now, what do you mean by pre-enteral follicle? I have specifically related to AMH, I'm explaining about pre-enteral follicles. So basically it is characterized by, we have a sudden enlargement of the oocyte from the primordial. Then there is a zona pellucida formation around the oocyte. Granulosa cell proliferation is noted along with formation of basal lamina layer. Then condensation of stromal cells to form the theca layer in that follicle. Then development of fluid filled spaces which gradually coalesce, you can see it on the right side, that gradually coalesce to form the enteral cavity. So in pre-enteral follicles, we do see a appearance of the enteral cavity. And if in case, if there is an absence of gonadotropic stimulation, then follicles develop until the early enteral stage and atresia occurs. So here we need FSH stimulation for the further growth. So this is a pre-enteral follicle. Now the next stage is an enteral follicle, which is normally measured by ultrasound, can be measured, that is in the size of say 2 to 7 millimeter. And it is specifically characterized by a cavity of antrum, which is containing a fluid termed as a follicular fluid. So you can see it in the ultrasound. These are all enteral follicles. And the terminology is enteral follicular count. That is what is number of enteral follicles seen in both the ovaries, which are in the range of 2 to 7 millimeter. That's total is called as enteral follicular count. Now, development of enteral cavity begins with the formation of the cavity on the one pole of the oocyte. So as you can see, a nicely developed cavity, and development of follicle precipitate within 60 days, the follicle reaches the pre-ovulatory stage. Dominant follicles means once we see the enteral follicle, it will get selected and then it will reach to within 60 days in a pre-ovulatory stage. Now, dominant follicle is something extremely rapid proliferation of granulosa cells and theca cells, which we will see, due to which it is correctively bigger size than any follicle during follicular phase. So, dominant follicle is the selected follicle into the follicular phase of the menstrual cycle. Now, we need to understand the definition of ovarian reserve. So the number and the quality of remaining follicles and oocytes in both ovaries at a given age is something as terminology has been given as a ovarian reserve at that age. Now it is used to determine the capacity of the ovary to provide oocytes that are capable of fertilization, resulting in a healthy and successful pregnancy. Now qualitative means what? That it helps to predict the pregnancy. That is a quality assessment of that oocyte. Now, what do you mean by quantitative? It helps to predict the number of mature oocytes. So that is a quantitative assessment of ovarian reserve. And when it comes to qualitative, it definitely helps to predict the pregnancy. Now, a natural process of oocyte loss, we need to understand that when a female infant up to 20 weeks, around 20 weeks, we have number of oocytes around 6.7 million in the ovaries, which reduces to 1.2 million at the time of birth, which further reduces to 3 lakhs due to apoptosis at menarche. So then from 3 lakhs numbers, approximately when she start ovulating, she loses one or at least 6 to 7 follicles each cycle. So ultimately at around say between 35 to 37 age, she has 25,000 cell left. And at the menopause, for close to 51, which is average age of menopause, it is just 1,000 cells. So there is a progressive loss of oocyte, as you can see it on the chart, that it from the fetal life to menopause is perfectly, it's a normal process, which is we need to understand that how the ovarian reserve goes down as the age advances. Now, what do you mean by aging and female infertility? So the quality of the oocyte, which is also appears to decline with increasing age, means what? In an early age, that is good reproductive age, that is between 18 to 35, we have a good quality follicles are getting selected to give a better quality of oocyte for the conception. But and after 35 years age, then we left out with more abnormal follicles, which gives you a more abnormal oocytes or probably bad quality oocytes, and that is why a natural conception goes down. Now, there is also an increase in the frequency of euploid and aneuploid spontaneous miscarriages with age, because we see a lot of meiotic spindle assembly abnormality in those sites from the advanced age. So greater proportion of degenerative oocytes were also seen in an older woman isolated during IVF. So somewhere the advanced age is not only changing the quality of the oocyte, but also it is containing a major associated with a large number of aneuploidic oocytes. Now, our monthly fecundity rate is close to 20%, and that decreases significantly after the age of 35. So around 35 age is considered a cutoff where beyond which there is a significant reduction in the monthly fecundity rate, as you can see it in the graph. Here you can see the graph is very steady, and then it goes down after the 35 age. Now, average singleton live birth rate of a female age, which steady decrease after the age of 34 years old, and poor response to ovarian hyperstimulation for IVF, especially in a decreased ovarian response reserve, is a predictor of a poor prospect of becoming pregnant and of reduced spontaneous fecundity and early menopause. So this ovarian response is somewhere related to the ovarian reserve. Coming to the important hormone, which is the anti-Mullerian hormone, and I think it is a very important hormone in our practice, not only for the assessment, but also for the prediction of certain outcomes of the fertility treatment. Now, AMH, which is known as an anti-Mullerian hormone, is basically a transforming growth factor from a beta family, and it is produced from a granulosa cells of the ovarian follicles. Now, it is considered as a most important predictor of ovarian reserve, which we'll see it in a few slides. Now, stage, growth development stage, it is produced by those pre-antral and early antral follicles. That is what I explained you about those pre-antral follicles, which are you can measure it on any day of the cycle. And to understand very important part of AMH, where production of AMH, it regulates the folliculogenesis by inhibiting recruitment of follicles from the resting pool in order to select for the dominant follicle, after which the production of AMH diminishes. So remember, I think we'll come to that in the next slide. So see, in a folliculogenesis, we have two important stages. One is the initial recruitment, and second is a cyclic recruitment. What do you mean by initial recruitment? Which is it is basically a primordial follicles, they start to become mature. That is the recruitment of primordial follicles is the first initial step. What do you mean by cyclic recruitment? Here, growth of a cohort of a small enteral follicles, among which one follicle will become a dominant follicle, and that will be completely controlled by the FSH hormone. Now we need to understand that AMH expression starts in a primary follicles. So if you remember the folliculogenesis stage, the primordials gets converted into primary follicles. So that primary follicles, as it happens, there is a expression of anti-Mullerian hormone and is enteral follicles. So when follicle growth becomes FSH dependent, that is after enteral follicle, AMH expression diminishes and becomes undetectable. Now this is very important step. If AMH do not, if it doesn't decrease, then probably follicle will go into atresia. So this AMH has got an inhibitory role at two stages in folliculogenesis. So AMH inhibits transition of follicles from primordial, that is initial recruitment what we discussed. So it inhibits transition of primordials into maturation stage, and thus it plays an important role in regulating number of follicles remaining into the primordial pool. And that is why we still keep on getting enteral follicles, because we have primordial pool which is available in the ovary, and that is why over the years we get a enteral follicular development. But this is done by the AMH because of its inhibitory effect. Now, also AMH has an inhibitory effect on a follicular sensitivity to FSH. So once the enteral follicle gets selected, okay, so as I said that initially AMH is expressed there. Once the follicle gets selected, AMH goes down, and because of which one follicle goes into dominance. So even selection of a dominant follicle is controlled by AMH by decreasing its concentration. Now, the most important about AMH assays, that is a test, which is a blood test, and it is expressed into 2 units. For all our rest of the world, it is expressed as a picomole per liter. And in Asia, we follow nanogram per ml. This is all depending on the kit or the reagent or the testing method which we are doing it. So let us understand an Indian scenario that is important. So what do you mean by optimal fertility? So when you have a AMH levels between 4.0 to 6.8, which is an optimum, that is a maximized fertility. When you call average or satisfactory fertility, when the AMH level is between 2.2 to 4. Now it will be considered as a low fertility if the AMH levels goes below 2.2, but the lowest cutoff of low fertility is 0.3. When it is called as a very low fertility or undetectable when it goes below 0.3. It has been also utilized to predict whether very high levels of AMH can help us to predict hyper response or hyper stimulation, and there the cutoff is used is more than 6.8. Now I have bring out these AMH levels into picomole also, because many times what we refer to our all the research papers internationally, they are majorly expressed into picomole. So we need to understand also at the same time what is picomole. So optimal fertility is between 28 to 48. Average fertility is between 15 to 28. Low fertility is between 2 to 15, and very low it is below 2.2. So just remember this so that it will help us to understand the studies. So levels of anti-Mullerian hormone in serum during the normal menstrual cycle. So we need to understand what happens. Do we get any changes into serum AMH levels during the menstrual cycle in a normal menstrual cycle? So in this particular study, which was done in 2016, women with a normal menstrual cycles and between the age of 18 to 45, they were selected. There were around 45 women were selected. Now, blood samples for AMH assay were collected on every fifth day within each cycle, 2 in the follicular phase and 3 after the confirmed ovulation, means after, during the luteal phase. Now, the new AMH immunoassay revealed that a follicular phase rise in the serum levels, particularly in women over the age of 30 years. So after the 30 years, they noted that the AMH is slightly higher in the follicular phase in the serum levels. Nonetheless, the extent of variation was not too large. It was only small. And sampling on any day of the menstrual cycle is expected to adequately reflect ovarian reserve. That was the conclusion. So the take home message is that we can do AMH in any time, any day of the menstrual cycles, so that it will help to predict our objectives. Now, when to do AMH? I mean, not the time, but in which scenario we utilize AMH assays to predict certain outcomes of reproductive treatment. So when we see on ultrasound, a transvaginal ultrasound done on the first visit, and we note that the total enteral follicular count is between 3 to 6 or below 6, then yes, we take a help of AMH to have a supportive diagnosis for a low ovarian reserve. If the patient's age is more than 38 years, we must assess the ovarian reserve by AMH test. Also, PCOS patients undergoing ovarian stimulation for IVF, because we know that PCOS is known to have a hyper response or hyperstimulation. So AMH, we will see whether AMH is helping us to predict those kind of responses. Then pre and post laparoscopic surgery for ovarian endometriosis, because we know that doing the ovarian endometriosis surgery, there is a loss of 20% of ovarian reserve after you operate on the chocolate cyst. So it's, if you have an AMH assessment pre-surgery and after the surgery, you can assess it, how much percentage of the loss of ovarian reserve is there. So there you take a AMH assay. Then pre and post chemotherapy or radiotherapy, again, these kind of therapies are going to reduce significantly the ovarian reserve. So it helps us to assess the ovarian reserve, what is left after the chemo or radiotherapy. If there is a hyperstimulation history, which is severe category, moderate to severe category, and patient had a history of such hyperstimulation in the past, before we do a further next cycle, it's better that we assess the ovarian reserve and AMH value to predict hyperstimulation. And now the newer indication, which probably will look into the future, that AMH will be helpful for diagnosis of PCOS. I won't get surprised if we have in future AMH levels assays and cutoffs, where we can say that if the AMH is beyond this cutoff, means a patient do have a PCOS. So these are the scope of AMH assays in our practice. Now we need to understand also at the same time that if we have a patient who is continuously on combined oral contraceptive pills, then the serum AMH levels will decrease significantly. And that is why this important history is very important before we send a blood sample for AMH assays, because this is the scenario where we'll have a false positive report of serum AMH predicting a lower response. Now, I wanted to give you a questions in our mind, that ovarian reserve predicting test, which is one of its AMH. So does it, where exactly it helps? Does it help to predict ovarian reserve? Number one. Does it help to determine the dose of gonadotropins? Means depending on the AMH levels, I am able to decide what dose I should give it rather than any other parameters. Does AMH assay help us to predict ovarian response to gonadotropins? Does it predict pregnancy also? That yes, if we have a good AMH, then yes, it will result into pregnancy. It gives us that assurity. These are the questions. Does it predict even OHSS occurrence? So all these questions we need to answer today in our presentation. We'll begin with this particular paper in 2013, which was an individual patient data approach and added value of ovarian reserve testing in prediction of ovarian response and ongoing pregnancy. That was the aim. Now this meta-analysis in 2013, they use age, FSH, enteral follicular count, and anti-Mullerian hormone as a predictor of ovarian reserve. And they demonstrated that and enteral follicular count and AMH, they clearly add to the age in predicting poor response. So instead of FSH, but these two parameters are going to help us in predicting the poor response in addition to the age. Now, as a single test, if we talk about, then AFC and AMH both fully cover the prediction of poor ovarian response. So both has got an equal capacity or probability in predicting the poor ovarian response. We can just do AMH and find out whether patient will respond poorly to our ovarian stimulation protocol. The clinical usefulness of these tests prior to IVF will be limited to the prediction of ovarian response. When it comes to prediction of ovarian response to overstimulation, little we cannot say that yes, we do this assay and we know the response of the ovary. No, it's difficult. In predicting the ongoing pregnancy after IVF, now if we want to predict the pregnancy, if so, age is the best single predictor, as we discussed, and we understand that if we do IVF in a younger patient, even if it is a lower reserve, there are chances of pregnancy are much higher when we compare with a low reserve in a elderly patient. So young age is the best predictor, and that is why when it comes to pregnancy prediction, age factor, it is always leading beyond the AFC and AMH. Now, role of anti-Mullerian hormone in prediction of outcome after IVF. So comparison with enteral follicle count. So this study by Dr. Simon, he compared whether AFC is superior or AMH is superior, and the radius under the curve is clearly shows that AMH has its at least same level of accuracy and clinical value for the prediction of poor response and non-pregnancy as enteral follicular count. So nothing is superior than each other. We can even take a help of either of the test to predict. So this particular type of study, which was a systematic review, they concluded that poor ovarian response will provide some information on ovarian reserve status, especially if the stimulation is maximal. Entering the first cycle of IVF without any prior testing seems to be the preferable strategy. So what do you mean by that? Suppose we have a patient whose AMH report says that it is significantly low. It is probably very low. But can we say that to patient that, okay, probably you need to undergo IVF with donor oocyte only? No, only on AMH report, we should not advise a patient that she should not go for her own ovarian stimulation. But if we have a history where a patient has already undergone one IVF cycle with a low reserve, with a AMH which is very low, and if we look into her oocyte performance in terms of blastocyst formation, and in her history, something like there was no blastocyst formation out of those minimal number of oocytes available from her ovary, then that is a proof where we can say next time that yes, you are supposed to undergo IVF with donor oocyte will be better, because we have the proof of that outcome of the first IVF cycle. But if she haven't undergone any kind of IVF cycle beforehand in the past, then there's no point in telling her to undergo not to undergo IVF cycle. So undergoing first IVF cycle is the best predictor of the ovarian response. Now, we need to understand about the age. I am bringing this particular study by Tokura in 2013 because they use specific age group as a cutoff, and they correlated significance of serum AMH levels in these patients. So here, over the age of 40 in the first IVF treatment. Now, patients were very specifically selected, age more than 40, and it was a first IVF cycle. So here the cutoff level of 1.0 nanogram per AMH can be used to predict poor ovarian response. That is what is they followed. And this cutoff level of 1 nanogram was useful to predict whether patient could have had embryo transfer and had no power to predict achieving pregnancy. So in these particular patients, our data or this particular group said that they showed that patients over age 40 with extreme low levels of AMH still had a chance of pregnancy. They detected certain number of pregnancies. Now, if we look into it, here the group of 128 women, they underwent 254 IVF cycles, where the AMH was between only 0.1 to 0.4. So it was very low AMH levels, but still 7.9% per cycle pregnancy rate they have detected, and total cumulative pregnancy rate was 15.6%. So it was never a zero. So these actual values we have to quote it to our patients when we talk to them when their AMH is between 0.1 to 0.4 nano. 13 out of total pregnancies were live birth rate, and 8 patients miscarried. So even at the same time, we have to discuss with them that even if you get pregnant, the percentage of pregnancy will be somewhere close to 60%, but 40% will be probably miscarriage rate. So this was a very eye-opening study, that sometimes even if it is age beyond 40 and AMH is below, we have to tell them that it is never a 0% pregnancy, but it is somewhere around 8% per cycle of starting the IVF cycle. Now, in this particular group by Dr. Wegofer in 2011, here 70 women were recruited whose age was less than 42 years age, and they detected almost 16 clinical pregnancies, 10 deliveries, and even 58 patients more than 42 years age, 4 clinical pregnancies and 2 deliveries. So the first group was less than 42 and the second group was more than 42. Still, the 3.4% live birth rate has been detected. So there is a reduced pregnancy chance, there is a reduced delivery rate when it was compared with versus the age more less than 42 age. So there is a significant reduction beyond 42, but it is never a 0%. So I think only on AMH assays we cannot say that with extremely low level of AMH, moderate but reasonable pregnancy and live birth rates are still possible, and that is why that paper which I quoted, that undergoing first IVF cycle is the better predictor of reproductive outcome or a live birth of the pregnancy. Now, AMH and prediction of ovarian hyperresponse. We have understood about the poor ovarian response. Now, what about ovarian hyper response? So this was a study in 2015. They wanted to find out the optimal cutoff value of AMH in infertile women for prediction of ovarian hyper response and poor response to stimulation. So they concluded that the optimal cutoff value was 6.95 nanogram per ml, beyond which there was a higher chances of prediction of OHSS. So OHSS happened with a sensitivity of 75% and specificity of 84%. And the optimal cutoff point for to discriminate poor response was 1.65 nanogram per ml with a sensitivity of 89% and specificity of 71%. So these, according to this paper, these were the cutoffs beyond which we can say a hyper response is possible and a poor response is possible. Now, prediction of reproductive outcomes according to the serum anti-Mullerian hormones in female in undergoing IVF cycle. The result was, suppose somebody's AMH is below 0.42, the rate of good response is going to be very, very low. And even if it is beyond 2.1 nanogram, then the rate of good response is almost in the range of 61%. So when related to patient when with the AMH of less than 0.4, the chances of good response were approximately 8-fold higher when AMH lies between 0.84 to 1.68. So or even if it is much better, that is 11-fold higher if the AMH is beyond 2.1. So why this study I wanted to bring it, because they concluded that in an individual patient seeking for ART treatment, the serum AMH level measured in a previous cycle, that can be used to predict the risk of cycle cancellation and the chances of good ovarian response. So if the patient has got a less than 0.4, it will help us to tell them that there is a higher chance of cycle cancellation. And even if it is beyond 2.10 nanogram, it helps us to tell them that your ovarian response will be much better. And that is where a AMH value can be utilized. But serum AMH was not as powerful as a predictor of oocyte quality in terms of fertilization rate, embryo development, and implantation. So it can predict the ovarian response, but it cannot predict the oocyte quality. So remember, it can be helpful for a quantitative assessment of ovarian response, but not as a qualitative ovarian response. Now, what about occurrence of pregnancy? Can we say that while assessing the serum AMH levels, it helps us to tell very confidently to our patient that yes, you can be pregnant because your AMH is good. So in this particular study, there were two main groups, where a good responder group, which was a group 1, had 75 patients, and a poor responder group where we had 35 patients. Now their result says that there were statistically significant differences between good and poor responding groups regarding duration of stimulation, number of HMG ampoules, number of eggs retrieved, and number of metaphase 2 eggs, fertilization rate and quality of the embryo, and both chemical and clinical pregnancy rate. So serum AMH level at the cutoff of 2.8 is more sensitive, specific, and predictive of a good quality embryos and occurrence of either chemical or clinical pregnancy. So when it comes to assessment of AMH for the occurrence of pregnancy, then the threshold goes higher. It is no more 1.8 or 2.1, then it is goes to 2.8 nanogram. So remember, so even AMH can be helpful for prediction of occurrence of pregnancy, but the threshold value is very high. That is around beyond 2.8 is the threshold value. Now, few papers have come up that we can assess the AMH and can decide about the FSH dose. So in this study, 221 patients were randomized into 2:1 ratio, where depending on the AMH, the dose was decided. That is called individualized dosing group. And 149 patients were recruited. And for a standard dose where the fixed dose was used, 72 patients were recruited. Now, according to the AMH level here, which was beyond 24 picomole. So here FSH dose was 100 IU per day. If the AMH level is between 12 to 24, then 150 IU was given, slightly higher dose. And when the AMH was below 12 picomole, then fixed dose, that is standard dosing group, was corifoliatropin, that is 100 to 150 IU was given. Now, they found that between these two groups, intended number of oocytes, there was no difference in any of these groups. So even if you don't do a AMH levels and give a patient a fixed FSH dose, we will get intended number of oocytes adequately from this patient. There won't be any significant difference between number of oocytes. Even they have compared cumulative live birth rate was not very different between individualized dosing doses according to AMH or a standard dosing doses. So AMH-based individualized algorithm did not increase the proportion of patients with an intended oocyte retrieval. So it doesn't help to decide perfect dose where we get our intended number of oocytes. Can we utilize, as I said, yes, in future, we may say that looking at AMH, we can say that she has a PCOS without doing any sonography or without having any hormonal assays. So in this case control study, they recruited 79 PCOS women and 69 normal ovulatory women, and the receiver operating characteristic curve, that is ROC, was used to determine about AMH as a diagnostic cutoff at 3.19 nanogram per ml, with having 72% sensitivity and 70% specificity. That was ROC was showing, and that is where they concluded that AMH cutoff of 3.19 nanogram can be very significantly correlated with PCOS, and we can say that those patients whose AMH is beyond 3.19 we can say that she does have a PCOS and can be utilized as a. So this is our future. Probably we might get these kind of parameters into our Rotterdam criteria, which we are using into diagnosing a PCOS patient. Now, different uses of AMH as a predictor of time to menopause in a reproductive age. So in this study, 101 late reproductive age women were recruited. Here 14-year follow-up in people who are from the pain ovarian aging study. They were recruited from 1996 to 2010. They were premenopausal women with a mean age of 41 years, 41.47 years, and their median AMH levels were 0.68 nanogram at baseline. Now, when baseline AMH for those patients whose baseline AMH level were below 0.2 nanogram, the median time to menopause from the time of assessment was 5.99 years in the age group, in the woman whose age group was between 48 to 48 years. Means what? All those women who were in 45 to 48 years age group, when their AMH was below 0.20, so time for menopause, median time of menopause were around 5 to 6 years. So within 5 to 6 years, she will have menopause. Now for a woman who were in 35 to 30 age group, when the AMH was below 0.2, they will get menopause after within say 9 to 10 years time period. Now suppose if we have a higher AMH level at say around 41 age, around 1.50, then in an older age group within 6 years, 6.23 years, she will probably face menopause. And if we have a patient who are younger between 35 to 39 years age, then her menopause will come after 13 years of age. So definitely AMH levels will help us to at least predict when a woman will get menopause. So it AMH is a strong predictor of median time to menopause in a late reproductive age group, and this was a conclusion by this group. But age and smoking are significant and independent contributors to the predictors of AMH. So suppose patient who is smoking, who is regular smoker, I think the age is going to further decrease. This particular median time to menopause is going to further decrease. So that is an independent factor which also changed the prediction of AMH for time to menopause. So friends, to conclude, ovarian reserve test do have a moderate ability to predict poor and hyper response. The information can influence the treatment protocols to be chosen for IVF and should not be used to exclude anyone from the first attempt at IVF. The present evidence shows that AFC and AMH appear to be the most useful markers of ovarian reserve in addition to the chronological age. So they are just additional markers than our age, which we consider as the best marker. Now, in addition, AMH has the ability to be applied to the general population for identification of diminishing ovarian reserve before it reaches to a critical level below which no effective treatment can be offered. So that can be something which we can apply. And AMH has been suggested to predict the ovarian response to hyperstimulation of the ovaries for IVF and timing of menopause, and also to indicate iatrogenic damage to the ovarian follicle reserve. AMH is actually a follicular gatekeeper limiting follicular growth initiation. We have already discussed in the initial slide, and subsequently estradiol production from small enteral follicles prior to selection. AMH assay continue to evolve, and technical issue remains with us. The absence of international standard is a key issue when we discuss about AMH assays, and that is why you have to select your lab from which kit they are using, because if we do 10 labs, we will see that AMH levels are vary because what kind of kits they are using. There are only very limited data on relationship between AMH and natural fertility at different stages of reproductive life. So you can't have a similarity. There is a variation of fertility at different age. Women with PCOS shows markedly raised AMH levels due to both increased number of small antral follicles and intrinsic characteristic of those granulosa cells. The value of AMH in the diagnosis of PCOS remains controversial, but it may replace AFC in the future. Probably that is what we are to look at future. So thank you very much for the patient hearing, and I thank you Lupin for inviting me to speak for this particular topic. And I hope that I justified your expectations and tried to give you the evidence in helping us to understand about AMH and its scope in our ART practice. Thank you very much.
Thank you so much, Kundan sir. So with your permission, can I take a couple of questions? Although
yeah, sure.
most part of the questions you have already covered in the slide deck.
Thank
and
you.
I would also like to tell you that we have received so many comments with the appreciation and with thanks. For example, Dr. Manpreet Kaur from Haridwar is saying that very informative talk. Thank you so much, sir, for making it so simple. Maybe one question, Dr. Lalis from Yelkar Reddy. She is asking that which day of the cycle is best to do the AMH testing?
Okay, so as I said in my initial slides, that actually speaking, we can do AMH levels on any day. So there is no fixed day where we can say that, okay, only on day 2 only we should do it, or on the day of ovulation we should do it, or we should do it in a luteal phase. It's not mandatory. The study which I have presented you has clearly demarcated that the variations are so small, the extent of variation is so small that it will not change our prediction. So I think I will suggest, according to the literature evidence, that you can do AMH on any day of the cycle as soon as the patient comes to you during your first visit, irrespective of the day of menses. If you see necessity of AMH levels, you can send the blood sample on the same day. But it is not, literature evidence is not there that any particular day only we have to follow. So you can do it at any day of the cycle.
Thank you, sir. So we will take just one more question because
Sure.
most of the questions have already been answered in your slide deck. Dr. Charu Smita from Jalna is asking that if the AMH levels are very low, which drug do you recommend mostly? And also, what is the significance of DHEA supplementation in these patients?
Okay. Uh, Dr. Vinay, you said which drug is preferred. Am I right?
Yeah,
Yeah.
yeah.
Okay. So I think what her question was, is there any need of giving any adjuvants before we do a ovarian stimulation, especially on a poor responder patient? I think her question was directed to that particular topic. Now, as we know that initially, like maybe 5 or 7 years back, we had lot many papers which were showing that DHA has got a role, or supplementation of DHA gives us a better oocyte quality. But remember, the receptors of DHA, they are absent on the granulosa cells. So we need to understand that even we supplement DHA and we increase the DHA levels in follicular fluid, it do not give a better oocyte quality, and that's the evidence. And that is why recently, last 4 years or 3 to 4 years, we have almost 3 or 4 good papers where it has been tested that instead of DHA, if we use a testosterone in the form of gel or in the form of any other administration form, then it has been documented that there is a significant increase in the ovarian response. Not only that, the the main purpose was to have a better oocyte quality, and that is something which has been documented, that with a good androgen, that is good testosterone levels in the follicular fluid, we have a better oocyte quality. And that is why I personally prefer, and even the with a literature backup, that if we supplement testosterone in the form of gel for say at least 60 to 70 days prior to ovarian stimulation for a poor responder or a low reserve patients, then you will the chances of getting a better oocyte, which will lead to a good blastocyst formation, and also at the same time getting pregnancy, is going to help us. So I think instead of DHEA, I will prefer testosterone supplementation to these patients. Now, also one of the very important adjuvant which I always prefer giving into this group of patient is the antioxidants. Because see, there are patients who are in this particular group are the elderly patients. If you isolate all the low ovarian reserve patients, almost 60 to 70% are patients which are beyond 34 to 35 age group. And it has been documented that the ROS concentration into the follicular fluid is very, very high in this age group. And that is why supplementing with these patients prior to ovarian stimulation with antioxidant drugs is going to be certainly very, very beneficial. So if any low ovarian reserve elderly patient, if I have to do ovarian stimulation for IVF, I will give it testosterone administration along with antioxidants combination, and prior to IVF cycle for 70 days at least minimum. And then only I will do the IVF cycle.
Thank you so much, sir. We have received so many comments. Dr. Rekha from Bangalore is saying that, hi, Dr. Kundan, congratulations for a wonderful session. Dr. Shweta from Morena is saying, nice webinar, very deep. So thank you so much, sir, for this wonderful session. And on behalf of entire Lupin team and also Foxy, President Dr. Alpesh Gandhi, sir, we are very grateful to you, and thank you so much. Have a nice day.
I want to say one last line. Being though I'm a chairperson of Infertility Committee, but I want to really congratulate our President Dr. Alpesh Gandhi for excellent academic activities, which has been planned at the start of the year, when actually the lockdown has started, and the meticulous planning by his all the team. I mean his of our office bearers from Foxy, helping us as a chairperson to organize many academic programs, and so that we don't want to overlap each other. But I think excellent planning by Dr. Alpesh Gandhi, President Foxy, and I really want to thank the Dr. Alpesh Gandhi as a president and all the office bearers of Foxy for inviting me to give this particular presentation and deliberation on this topic. So
thank you
thank
so
you
much,
very
sir.
much again.
It's a privilege for us also, for Lupin also, to partner in these kind of scientific initiatives. Thank you so much. Have a nice day, sir.
Thank you.
Stay safe.